Here we demonstrate normal gait. Series of rhythmical alternating movements of the trunk and limbs which result in the forward progression of the center of gravity. Stance phase, reference limb in contact with the floor. Swing phase, reference limb not in contact with the floor. Here we demonstrate antalgic gait, also known as painful gait. Sets the foot down, bears as little weight on it as possible and limps off the foot as soon as possible, while wincing and hunching the shoulders. Causes arthritis, trauma and gout. Diseases distal peripheral neuropathies. Here we screen cautious gait, also known as senile gait. Patient walks with an abbreviated stride and lowered center of mass. Slow velocity, short steps and wide pace. Walking on a slippery surface. Causes age-related degeneration of sensory apparatus. Diseases Alzheimer's disease. Treatment physical therapy. Here we have the demonstration of cerebellar gait. The disorders of the cerebellum have drastic effect on gait and imbalance. It is characterized by wide-based gait, lateral instability of trunk, erratic foot placement, decompensated balance when trying to walk tandemly, lacks position sense. Difficulty in maintaining balance when turning is often an early feature. Unable to walk tandem heel to toe and show truncal ataxia in tandem stance. Causes would be stroke, trauma, tumor, neurodegenerative disease, including multiple system atrophy. Here we film foot drop. Patient toes do not clear the floor because of paralysis of foot dorsiflexion. Lifts leg too high, drops it with high force. Causes unilateral peroneal palsy, pyramidal lesions, L5 radiculopathy, bilateral peripheral neuropathy. Here we screen freezing gait, most commonly seen in people older than 55 years. Stoop posture, small pace, no arm swing. Shuffling gait, upper extremities are usually flexed at shoulder, elbow and wrist. Fingers usually extended. A brief episodic absence of forward progression of feet despite the intention to walk. Causes tardive dyskinesia due to chronic use of antipsychotics. Diseases Parkinson's related neurodegenerative disorders such as progressive supranuclear palsy, corticobasal degeneration and Huntington's disease. Here we have the demonstration of frontal gait. Shuffling, freezing gait with imbalance and signs of cerebral dysfunction. Wide base of support, short stride, shuffling along the floor. It is also called as slipping clutch syndrome or gait ignition failure. Causes would be the vascular diseases, lesion in the deep frontal white matter and centrum ovale. Diseases will be hypertensive patients with Binswanger's disease, communicating hydrocephalus and cerebrovascular diseases. We screen hemiplegic gait, circumduction of leg, dragging the toe, placing the ball down without a heel strike, with the ipsilateral arm held in partial flexion or more rarely flaccidity at the side. Affects the arm or hand more than the legs. Usually causes a closed fist due to flexor spasticity. Causes would be stroke, multiple sclerosis, diseases, unilateral upper motor neuron lesion. Here we perform marche à petite passe. Small pace, won't lift the feet, far from the floor. Upright posture, normal arm swing. When the patient tries to speak, steps cease. Causes would be diffuse cerebellovascular disease, lacunar state. Diseases caused would be bilateral diffuse cortical dysfunction. Here we picturize orthopedic gait. One limb is shorter than the other. Causes would be previous hip surgeries and trauma. Here we demonstrate psychogenic gait. Common neurologic practice, extreme anxiety or phobia have exaggerated caution with abduction of arms as if walking on ice. Depressed patients exhibit primarily slowness, a manifestation of psychomotor retardation and lack of purpose in their stride, odd gyrations of posture with wastage of muscular energy. Astasia, abasia, extreme slow motion and dramatic fluctuations over time is seen in patients with somatoform disorders and conversion reaction. Here we film scissoring gait, crossing over legs while walking, adduction of legs strongly while walking, normal arm swing, causes cerebral palsy, multiple sclerosis, cord compression, diseases, spastic paraparesis. Here we screen sensory ataxia. Balance depends on the high quality of afferent information from visual, vestibular system and proprioception. Joint position and vibration sense is diminished in the lower limb. Stance position is destabilized by eye closure, patient exhibiting positive Romberg sign. Patient tends to look down on their foot when walking and do poorly in the dark. It is characterized by wide-based gait, feet separation, high stepping and foot drop, mostly seen in diabetic neuropathy, diabetic neurosyphilis, vitamin B12 deficiency and Meniere's disease. Here we demonstrate spastic gait, also known as stiff leg gait. Imbalance of muscle tone, tendency to circumduct and scuff the feet, walks on toes, positive upper motor neuron signs. Causes myelopathy from cervical spondylosis, spinal cord injury, multiple sclerosis. Diseases, cerebral spasticity, dystonia, stiff person syndrome. Here we screen waddling gait, rolling gait in which the weight-bearing hip is not stabilized. It bulges outward with each step while the opposite side of the pelvis drops, resulting in alternating lateral trunk movements. Causes would be proximal myopathies, bilateral congenital dislocation of hip, diseases, weak or insufficient proximal muscles. Here we film functional gait, a non-specific gait associated with incoordination of movements. Variable, may be inconsistent with the rest of the physical examination, may be mistaken for gait in chorea. Involuntary jerks involving shoulder, hip, face, which is shuffling, twitching and spasmodic. Patient may exhibit wibble and wobble but do not fall.